Okay, so we're just going to be going over sort of a whole bunch of things because they're all sort of short and can be combined. But just to review medication administration, diagnostic tests, pain, and palliative care. So pain meds, we want to make sure we remember acetaminophen or Tylenol reduces fever, pain, but not inflammation like NSAIDs and aspirin does. This is easier on the GI system, so better for geriatric patients, but pretty harsh on the liver. So just remember there's an antidote, acetylcysteine sulfate. And then NSAIDs include ibuprofen, ketorolac or Toradol, naproxen, and aspirin. So ibuprofen, Advil, or Motrin can be rough on the GI system. Watch for bleeding, so like tarry stool or bloody vomit. Toradol, careful with asthmatics or those with like a ton of allergies because it can cause anaphylaxis. Um, Aspirin, we're never giving to children because it can cause Ray's syndrome. But the baby aspirin dose or 81 milligrams can help those who had or have coronary artery disease. It decreases the risk for myocardial infarction. And then if you had a heart attack, you take a baby aspirin every day to decrease the risk of having another heart attack. For neuralgia, so nerve pain, there's gabapentin and pregabalin. Opioids, of course, we're watching for respiratory depression. You give Narcan if they have a patch on, so they have like a fentanyl patch or something on. Obviously, you want to take that patch off before you give them Narcan, or if that patch is on, it's going to continuously be delivering that fentanyl, and no matter how many doses of Narcan you give them, they're going to keep crashing. Okay. Opioids can increase the risk of fall for elderly patients and others, and also usually cause GI disturbances. So there's fentanyl, hydrocodone. Hydrocodone is also a cough suppressant in low doses. Oxycodone, tramadol, and morphine. Make sure you know the trade names for all of these. That will be important for your final OSCE. Morphine PCA, just remember only the patient can push the button. Push when the pain is rising, not when the pain is at its worst. So we're controlling pain, and it's just easier to do when it's at lower amounts. Okay, so antidotes that would be important to remember: Romazicon reverses conscious sedation, benzodiazepines, and general anesthesia. Prostaglandin and some sugammadex, I don't know, just read it, reverses neuromuscular blocking agents. Okay, and I guess another important one for neuromalignant syndrome, so like hypermalignant syndrome or whatever, after anesthesia, some people get like really, really high fevers. Dantrolene is the reversal agent for that. Okay. Medication administration reminders, just remember quickest routes from like left to right: IV, subcutaneous, IM, PO. IV, recheck pain in about 15 to 30 minutes, PO about an hour. Remember, nurses can't change the routes of medications, so contact the doctor. However, if they can't swallow pills and you're wanting to give them a liquid form, it's still PO, so you can still call the pharmacy and ask that without having to change the order with the doctor. If you want to crush the pills, make sure you contact pharmacy to ensure that it's safe to do so. If you are splitting pills in half, you can't split them unless they are scored. So they have that little line down the middle. Pharmacokinetics is how the drug moves through the body. So kinetics, movement. That includes half-life, peak and troughs for antibiotics, side effects, adverse reactions, synergistic and antagonistic reactions, and IV incompatibility. You know, you're obviously checking compatibility through like that online checker in clinical pharm. But another way to tell if it becomes cloudy or precipitates form, we know it's incompatible in the IV. Pharmacodynamics is how the drug interacts, like it causes a response in the body. So that what we want to happen in the body. Just remember for eardrops, up and back for adults. And just remember adults are taller, so pull back and up, and then down for children because their eustachian tubes are shorter and straighter. Eye drops, make sure to put pressure on the tear duct, like about right here, to avoid systemic absorption. Don't touch the dropper right to the eye. Don't drop the drop right onto the cornea. Aim for like the lower sac right there. Wait about 5 minutes in between each one. If you have to do an ointment and an eye drop, do the ointment first, or sorry, do the eye drop first, wait 5 minutes, and then do the ointment. We're always moving from inner canthus to outer. Um, let's see, corticosteroid inhalers. We want to rinse the mouth afterwards so that there's no Candida albicans infection, so yeast infection. Also with corticosteroids, we're watching for rapid weight gain. So report rapid weight gain if they're on steroids. Make sure you remember your 6 rights. Remember the patient has the right to refuse the medication and they to know what they're getting. So we're never hiding a medication in a milkshake, even for like psych patients who are refusing their meds. Okay. Psych patients still retain their rights to refuse unless overridden by the state. Clarify the order with the provider, not the person like the messenger, like the pharmacy or anyone like that. If you have a question about the order, talk to the provider. Diagnostic test review. So x-rays, we want to protect ourselves from radiation. For all females of childbearing years, they need a pregnancy test before they get an x-ray, usually just through a urinalysis. CT scan is a type of x-ray, usually using contrast dyes. So we're assessing for allergies, especially like shellfish, iodine, stuff like that, as well as kidney damage, and adding to that, checking to see if they're on metformin. MRI, no metal. If you have tattoos, they may burn. They may need an anti-anxiety medication because it's claustrophobic. It takes about an hour to get an MRI. Esophagogastroduodenoscopy. They got to remain NPO until their gag reflex returns because they're numbing the gag reflex so they can stick the scope down. Bronchoscopy, again, they're going to be NPO after midnight, so no feeds, head of the bed up, stuff like that. EKG, telemetry, we talked a lot about that in previous videos. A centesis means like a needle drainage. A thoracentesis, they're going to be sitting up so that all the fluid drains to the lower lobes and they can pull it out. And they may need a chest tube afterwards. Cardiocentesis, it's very possible they may get an gosh, guys, I can't speak. Iatrogenic pneumothorax. So iatrogenic is caused by a medical procedure, so they may accidentally puncture the lung. Okay, so be listening to breath sounds, and if you don't hear breath sounds in a certain area and they're having trouble breathing, possible pneumothorax, in which a chest tube would be inserted as well. Sputum collections, best in the morning, can be delegated to a UAP. It's just the most concentrated in the morning before you drink a bunch of water. Same thing with like urine if you're doing a pregnancy test. Clean catch urine specimen. So with suspected UTIs or they have burning, you want to get a clean catch. And you're just going to wipe, instruct them, give them 3 towelettes, wipe for the labia on one side, the other side, and down the middle. For men, just each wipe, a swipe around the meatus. And then pee first into the toilet, and then as they're peeing, catch with the cup, and then finish peeing. And then 24-hour, we talked about in the last video. Okay, pain. So pain, everybody experiences it. It's very subjective. So make sure to do a thorough PQRST. There'll be questions about PQRST always, I feel like. So subjective is best, but objective signs can also be seen with pain. So especially in like the PACU or ICU when verbal response may not be an option. So you'll use like the FLAC score to determine somebody's pain. So you can see increased vital signs. They're agitated, confused, they're guarding, groaning, stuff like that. Pain can delay healing and disrupt normal processes like sleep. So pain needs to be controlled. Okay. An example is herpes zoster, like shingles. That kind of pain can disrupt sleep. I don't know where I heard that, but I just remember that. So nociception in regards to pain is determined by like transduction, transmission, and perception and modulation. So transduction can be mechanical, thermal, chemical, and that turns into an action potential. So let's say I touch a hot stove, action potential sends to my spinal cord to transmit it through neurons and then up to my brain where my brain perceives the pain and then sends out a signal to modulate. So, and then once that signal is sent out to modulate, I'll pull my hand away because I recognize the pain. Nociceptive pain. So nociception, this is that specific pattern. So nociceptive pain follows that pattern. And because it follows the pattern, it's easier to control. So this is like your somatic pain in your bone, joints, muscles, skin, connective tissue. It's deep, aching, sharp, or throbbing, or visceral, according to the organs, like achy, cramp, pressure, or referred pain. Remember, like visceral pain, most of the time you just need to give a medication to relieve it because it's so deep. Neuropathic pain does not follow that pattern, so it's harder to control. It's more like numbness, tingling, burning, shooting pain, itchy. It's usually chronic. So, acute pain is less than 6 months, controlled by A fibers, are sharp, fast, and myelinated. Chronic pain are controlled by C fibers, so non-myelinated, slow, dull, achy. So, exact opposites of each other. Just remember with chronic pain, there can be breakthrough pain, usually happens with cancer patients. Breakthrough pain comes in waves, so they're getting opioids to control their pain, but somehow that pain broke through and they're like it's a 9 out of 10 pain. So cancer patients definitely need to be on round the clock pain medications and may need PRN morphine for spikes in pain. The goal for chronic pain sufferers is to complete normal life tasks. Like if the patient wants to play golf without the pain stopping them, that's your goal. That's what you're going to try and help them accomplish. Because oftentimes you will not be able to completely remove that pain. Just control it. Okay. So they can do normal things. Remember that just because they're old does not mean they should be in pain. It's not good to say like you're old, it's to be expected. Also with medication administration for elderly patients, remember to start low, go slow. So elderly patients metabolize medications differently, so you don't want to start them off with a crazy high dose. Tolerance can be gained. So chronic exposure to pain medication can increase the need for more pain medication in the future to achieve the same effects. And this happens a lot with cancer patients. Physical dependence happens and it can lead to addiction. You're going to experience withdrawal. It's just when you just take a medication for a long time and then stop, you can go through withdrawal. Sometimes a drug is given to prevent withdrawal while other medical problems are dealt with. So an alcoholic is in withdrawal at the hospital, but they also have, I don't know, like a broken leg. Like they might give the alcoholic like a beer from their medication fridge just to prevent those bad symptoms while they're treating the broken leg to avoid further problems. Just depends. Risk for dependence is low if medications are taken as prescribed for when you're in pain. So that's good to educate your patients on, unless they have addictive personalities or family members with history of addiction. It's very unlikely that if they take it as prescribed that they will get addicted to pain meds. Addiction is loss of control, craving, or compulsive use of drug when it's not necessary. Um, if someone is a drug seeker and they're in pain, usual procedure is to follow orders and give pain medications. So we're not really opioid gatekeepers as nurses. Okay, palliative care. So palliative care treats symptoms. Goal is increase quality of life, includes curative care or hospice. So palliative doesn't mean you're necessarily like giving up, I guess you can say. You just are trying to help control symptoms so you can have a better quality of life. Hospice, though, is no cure, no treatment. It is a terminal diagnosis. You're confirmed to have less than 6 months to live by two different doctors. And that's how you meet hospice criteria. Um, Brain death versus death. So death symptoms, signs and symptoms, commonly like Cheyne-Stokes, death rattle, air hunger, dyspnea, grief, fear. You want to prevent pain, skin breakdown. We want them to die peacefully, and like it might not make a lot of sense to be like doing oral hygiene or like turning somebody who's going to pass in a couple hours or a couple days. We never know exactly when they're going to pass, and we don't want to make dying more complicated by them getting a pressure ulcer, because then that just increases their pain and makes them leaving this world a little bit more uncomfortable. Okay. Um, so the last thing to go is said to be hearing. So encourage family members to talk to their loved one, even if they don't respond. That's just some good teaching to do. And then make sure we understand advanced directives and DNRs. There was an interesting case at my capstone the other day where a patient, she doesn't even speak English. She's been basically bedbound and nonverbal for 3 years. Her caretaker, they're from Laos, and her caretaker said that they communicate through like eye contact or something like that. Interesting. But because this patient's nonverbal, she never established like a living will or anything like that. And so she has no like advanced directive or DNR, and she doesn't have any family here. and the caretaker is not related to her, and so she can't make any medical decisions. And so that case is going to end up going to an ethical board at the hospital because they don't know if she's a code status, like what her code status is. They don't know if they should resuscitate her. They don't know this patient's wishes. And so it's really, really important that you establish, like when it comes time, your advanced directive and living will, because that would just be an awful situation to be in. But know your patient's code status. Um, so if something unnatural happens, like the DNR starts choking, like that's an unnatural way to die. You're still going to do CPR to resuscitate them in that case. You're not going to be like, oh, they're choking. They're going to go now, you know? So some practice questions. Okay, home health nurse visits a 40-year-old patient with metastatic breast cancer receiving palliative care with symptom control, experiencing pain at a 7 out of 10, prioritizing activities. What should the nurse do first? And so this is palliative. We're doing symptom care. They have cancer. Cancer priority is pain. So the answer is B, administer PRN pain meds. The rest of the stuff is great things you're going to do, but priority, like none of the stuff's going to matter if this patient's still in pain. Also, you should address patients' concerns first. So if they're saying I'm in pain, you should address their pain first. Okay. Caring for dying wife. Husband states wife is devout Catholic, but he's a Baptist. Who is considered the most reliable source for spiritual preferences concerning end of life care for the dying wife? And so the answer is B, the dying wife. So patient's wishes and comfort supersede anyone else's wishes, even the husband's. Okay. Visiting the wife of a patient having difficulty making transition to palliative care for a dying husband. What is the most desirable outcome for this couple? D, they acknowledge the symptoms and the prognosis. Understanding and acknowledgement make the process so much easier for end of life care. A, B, and C aren't realistic in terms of the fact that her husband is dying. Express hope for a cure. Well, her husband's dying. It's better to be realistic at this point. B, they comply with treatment options. Palliative care for a dying person is not going to be focused on treatment. And set additional goals for the future. The future is very unclear. They probably don't have a lot of time left. So, acknowledgement is the best outcome for this couple. Okay, visiting with a dying patient. During the interaction, the patient is silent for some time. What's the best response? So this is a lot of these questions deal with therapeutic responses. The answer is A, recognize patient's need for silence and sit quietly. B, try distraction. There's a reason they say the patient is being silent. If the patient's being silent, just wait for them to start talking again. Don't like interrupt unless, I don't know, very rarely. C, change the subject, try to stimulate conversation. No, you don't need to talk right now. Leave the patient alone for a period. They're probably not emotionally stable enough to be left alone. You should just sit there and offer presence as support. Okay. Terminal cancer. I know I'm going to die pretty soon, perhaps next month. Which is the following is your most appropriate response? The answer is A. What are your feelings about being so sick and thinking you may die soon? This is a pretty open-ended question, and just ask them like, how are you feeling? B. None of us knows when we're going to die. Is this a particular difficult day? Well, it is terminal cancer, so he knows he's going to die pretty soon. So not very therapeutic. Would you like me to call your spiritual advisor so you can talk about your feelings? Well, that's passing responsibility on. Also, you can talk about feelings with this patient. And that's assuming something that the question didn't give us any answers about if this person is meeting with a spiritual advisor. D, perhaps you're depressed about your illness. I will speak to the doctor about getting some medication. Just acknowledging that they're going to die pretty soon doesn't mean necessarily they're depressed. That's why asking, like, what are your feelings about it can help explore more about how he's feeling. So just an open question. Okay, so titrating for priority goal, we want to administer the smallest dose possible that provides relief with the fewest side effects. That's pretty much the goal for most medications. Okay. Okay, which client has the greatest risk for respiratory depression while receiving opioids? The answer is A, elderly chronic pain patient with a hip fracture. Being old, having chronic pain, they most likely need greater doses of opioids to control it. Yeah. Okay, really that age is that big indicator there. Okay, so delegation. The answer is A, assist with the preparation of a sitz bath. That's a hygiene thing a UAP can do. Monitor for signs, that's assessment and evaluation. Coach the client, that's teaching. Evaluate, that's nurse's role. Okay, PCA pump reports the pain control is inadequate. What first action should you take? So this is your first thing you do is assessment following ADPI. So assess for PQRST, essentially, before you try pain control measures or increase the dose or deliver bolus dose, right? Assess before interventions. Best way to schedule medication for a client with constant pain, like for example, cancer pain, would be D, around the clock. And that is it. Short and sweet.